Thank you very much. Good morning, everyone. So, biomechanics, before and after. What I'd like to do is focus on one aspect in a short 8-minute talk. We can't talk about the whole biomechanics. So I want to focus on the posterior slope. Before, in terms of its definition and measurement, and after, the effect that has on our knee performance and the importance of the posterior slope. Now, why is it important? Well, we kind of all know about femoral cut. Is it the same? We have a choice that we make. Is it the same for the posterior tibial slope? And if we ask the surgeons, we get a variety of answers about what posterior slope they're putting in to their patients. If we ask the companies, some of them tell us 0 degrees, some of them tell us 7 degrees, so it's variable from the companies as well. And if you look at our publications, we're quite interested. There's 10,000 publications on the posterior slope, but not as many as femoral rotation, for instance. So it's the poor relative of some of our alignment aspects is the posterior slope. But I'm going to tell you the posterior slope is equal in importance to femoral rotation. It's important because it allows a lot of functions of the PCL, it encourages rollback and prevents slide forwards. And it also allows the implant to be perpendicular to the Haversian canals. It makes a difference, and there are over 35 publications about the posterior slope and how it affects the kinematics and edge loading of the knee. How do we measure the posterior slope? We can measure it from the middle of the tibia. Some people measure it from the back. Some people measure it from the anterior cortex. But the problem is that gives us 3 different answers. Which part of the tibia should we measure from the back of the tibia plateau, from the middle, or from the front? Once again, 3 different answers. The rotation of your film is very important. This is the same patient. Now, that's the measurement, 7 degrees. If we rotate the film a little bit, or it's not taken properly, we get an answer of 12 degrees. And you can see how, by looking at the fibular head and the patella, how that film is rotated. So the importance of that rotation is if we have a slope and we cut in valgus or varus, that makes the flexion gap very variable and leads to the possibility to flexion instability. So the tibial slope is really important in terms of how we put our knees in. The next worst thing about the tibial slope is not flat. We think of it as a flat line, but it's actually not flat, and it's also not static. We know about the differential movement of the femur on top of the tibial slope. So it's a dynamic movement, and it's not only dynamic, it's asymmetric as well. As we know from this work, now it's over 30 years old, we expect to see much more movement on the lateral side of a tibial slope. And of course, that would happen because of the popliteus, and you can see the posterior ligament capsule here, ensuring that we have more lateral rollback on the side. And that's also dictated by the asymmetry of the femoral condyle, that big wheel, little wheel approach. So, when you thought you knew about the tibial slope, there are 6 different ways to measure it, and during that variation, we may alter our view by about 40%. The tibial slope is not flat. On one side it's convex, on the other side concave, and it's variably modeled by the soft tissues. The movement across the slope is asymmetric, and it varies dynamically with the degree of knee flexion and loading. So it's super complex. In fact, it's not a slope at all. It's a complex viscoelastic 3-dimensional structure which functions variably depending on how our foot and our heel hits the floor. And the movement across our tibial slope is probably never the same twice. So, how do we understand a tibial slope? And when we say we're going to cut it at 3 degrees, do we really know what we're doing? Remember, we asked these 100 surgeons, and we said, okay, what are you going to cut the tibial slope at? Interesting for surgeons, not one of them said, I don't know. But you can see, really, we don't have a great grasp of the tibial slope and how complex it is. So how do we do this in knee surgery? Well, we can try and match exactly all those things I talked about, the asymmetric condyles, the differing radii, and we can have a complex ACL, PCL cam. And that means that everything has to be in perfect orientation for the features to work together. And if we don't get everything right, that results in a kinematic conflict. So making a very complex knee may actually lead us to kinematic conflict, if you like, with the features working against each other. So we know we've had work on how accurate we have to be when we put these things in, and actually we can show that many of us make quite substantial errors. And there's a Stulber's paper showing that only 20% of our cuts are within 3 degrees of accuracy. So putting a very complex knee in very accurately is quite demanding. So even if we get it in accurately, because the knee is functioning dynamically, it's very difficult to get it right every time, because every step we take is different. So this is the problem we have with the mechanical replication of soft tissue structures. We might get it right once, but we're going to get it wrong a lot more often. And so that's our issue as knee surgeons. It's such a complex structure. How do we modify it? How do we make it work for us? So because it's a complex 3D surface, it may not be the simple slope we think it is. And it's very difficult to replicate that mechanically. So we can't replicate that mechanically. So what we've got to do is build in some tolerance. We have an engineering solution. And we have this concept of a kinematic envelope into which we're going to put our knees. So this is biomechanics before and after. Let's look at after now. Let's look at the effect of biomechanics of the tibial slope on the performance of a total knee. So here you can see there are two predictive FEA dynamics done in Southampton. 2 knees, one at 3 degrees, one, and the same knee now put in at 7 degrees. Can you see the knee that's moving at 7 degrees is actually lifting off? Now, I'll just go back a little bit because those really should loop. I don't know if we can make those work. I'm sorry about that because I rather hoped they would work. Let's try that. Can we just move the videos again? That's great. So you can see that knee is actually working well at 3 degrees, but you put the knee in at 7 degrees, if we can work that video, can you see that its lateral side lifts off? So the same knee, just at a different tibial slope, will actually have lateral lift-off because of the tibial slope. Now remember that 3 degrees really suited that model of knee. If we go to the next video, okay, so same 3 degree slope, different knee prosthesis. The 3 degrees work for the first prosthesis. Second prosthesis, you can see, is unstable laterally at 3 degrees. This knee is modeled for a 7 degree slope, but at 3 degrees, it's actually unstable. And the soft tissues are also slope dependent. Same knee with the same soft tissues at 3 degrees, and now the surgeon cuts it at 9 degrees in that other animation. And can you see that green and blue are physiological stresses? Red is supraphysiological and painful. So you can see altering the slope in the same knee makes a difference to the soft tissue pain. Now, it's important, the slope, because it makes the movement of the knee much more smooth. So when the cam engages and moves backwards, the tibial slope determines the speed at which the cam engages. And so the choice of tibial slope is actually knee design specific, not necessarily the surgeon's choice, but the designer's choice. And the knee is designed to move with a particular tibial slope, and it's the engineer tolerance you need to listen to. So, in summary then, biomechanics of the knee before, the natural tibial slope is a complex 3D viscoelastic structure, and we probably can't replicate that artificially. So the prosthetic tibial slope determines the kinematics of a TKA. And when we think about that, the tibial slope is defined by the prosthesis design, not really our choice. And it is design dependent and a major factor in knee performance. And so these are the things we usually talk about in knee alignment and putting in the femur and tibia. I think tibial slope should be right up there as important as them all. Thank you very much.